So we do the uterus first, and we have several slides, altogether 4 slides from the uterus. So it's a little bit more complicated topic. And here you have to know the cycle again with the hormones, as I said last time when we met, that the cycle you have to learn it very well. Okay, so you learned the macroscopical details in anatomy. I just repeat some of the things we have to know for histology too. Uterus has a body, the corpus, and the cervix. These are the 2 main parts of the uterus, and they are histologically different as well. And the corpus wall, uterine wall, has a different histological structure than the cervix, but the main layers are the same. The endometrium, the myometrium, and the perimetrium. This is the usual layers of any layered organ. Actually, that we first have a mucosa, a mucus layer, then a muscular layer with smooth muscle, and then adventitia or serosa, depending on whether the organ is intraperitoneal or not. The uterus is almost entirely intraperitoneal, although it's infraperitoneal, but it's kind of comes into the peritoneal wall that it's almost entirely intraperitoneal. So it is covered by a peritoneal layer. That's why it has a serosa, which is the perimetrium. And histologically, of course, the serosa is mesothelium, simple squamous epithelium. So this is, of course, the same in the body and the cervix as well, but the details are different. We started outside. I explained a little bit more in detail already the serous layer, and the myometrium is coming, and then we talk a lot more about the endometrium, because this is what undergoes the cyclic changes, so what has to be discussed very much in detail. So myometrium is of course smooth muscle, and you heard about the myometrium of the uterus already in the first semester when we did the smooth muscle, histology of the smooth muscle, when we learned the size of the smooth muscle cells, because you remember that it's very variable depending on whether we are in a blood vessel or in the intestine or in the uterus. The size, the length of the smooth muscle cells is very variable. And in the uterus was used as an example as having the longest smooth muscle cells. Even non-pregnant uterus has 100, 200 micrometer long smooth muscle cells, and during pregnancy it can be, of course, even more, 500 to 800 micrometers, so a very, very long smooth muscle cells. It has several layers within the uterus: inner longitudinal, middle oblique and circular, so more like a spirally arranged smooth muscle layer, and then outer longitudinal. Details of this will be very important in obstetrics, because these different layers react differently during contractions, during childbirth. What we have to know for histology as well, that these smooth muscle cells are hormone sensitive. I'm sure you all heard about oxytocin, which induces contractions during childbirth and during orgasm. So oxytocin, and the oxytocin sensitivity increases at the end of pregnancy. So that's why this is responsible for the uterus contractions, the strong contractions during childbirth. And because of this hormone sensitivity and proliferation capacity of the smooth muscle layer, unfortunately, abnormal growth is also very common. We have the fibroid or myoma, which is a benign growth of the smooth muscle, actually a tumor, a benign tumor of these smooth muscle cells, which of course can cause a lot of problems and heavy bleedings and have to be removed usually. So let's see the the endometrium more in detail. This is the mucus layer of the uterus wall, and this whole thing is the endometrium. Here you can see the myometrium underneath. This is smooth muscle. Of course, as every mucous membrane, it has an epithelium and the underlying lamina propria. The epithelium is simple columnar. Some of the cells are ciliated, but most of the cells are not ciliated, but simple columnar epithelial cells. And the lamina propria is a very special connective tissue, is not loose connective tissue. Please don't say that. If you look at this picture, even with this magnification, you can see that this is not loose connective tissue. It's very densely packed with cells. So just like in the ovary, we saw the last time, this is the so-called spinocellular connective tissue or cell-rich connective tissue. It's very densely packed with cells. This is called stroma, okay? Cell-rich connective tissue or stroma. And this is further divided into a so-called basal layer or stratum basale and the functional layer or stratum functionale. The functional layer, especially in the later stages or phases, can be further divided into a compact and the spongy layer. Why is it called functional layer? Because it undergoes changes. This is the function of the uterus, undergoes changes during the cycle. So it only looks like this during a certain time of the cycle. The stratum basale or basal layer does not change during the cycle. This is what remains. At menstruation, we lose the functional layer. So the functional layer is shed off. And what remains is the basal layer from which the whole endometrium can be replaced, can regrow. So this is the importance of these two layers. So this is the epithelium as it looks like, and then underneath the epithelium, look at this very densely packed stroma. This is the spinocellular connective tissue that I already mentioned, and you can see many, many glands embedded in this stroma. So we have to talk about the during the cyclic changes, the changes and growth of the stroma cells and of the glands. And here you can see these glands which look like tubular glands in a section, and they actually look like this in 3 dimensions. And you can see that these are simple or slightly basally branched tubular glands, okay? Simple tubular or branched in the basal part glands, simple tubular. And how is it possible, you could ask, that part of the stroma, part of the layer is shed off during the menstruation and part of it is not? Because they are supplied by different blood vessels. You can see that the basal layer, the stratum basale, is supplied by the so-called straight arteries. The blood supply of the uterus is extremely good, and big blood vessels supply the wall from which these straight arteries grow out. Okay, straight arteries supply the basal layer, and then you can see these spirally growing arteries, which are called spiral arteries. These supply the functional layer, and they have different hormone sensitivity. So this explains why the upper layer will be shed off, because it reacts differently to the hormonal changes. So we always have to talk about these 3 things: glands, the stroma, and the vessels. And I have to use this picture again that I already showed you the other time, which where we have the cycle summary. Very important that you learn the basics of the hormonal cycle, and you understand this hierarchy from hypothalamus, pituitary gland, ovary, and uterus. Okay, hypothalamus acting on the pituitary gland with FSH and LH acting on the ovary. The ovary is producing the ovarian hormones, estrogen and progesterone. And this acts on the uterus, on the endometrium, and causes these changes. So this is extremely important that you understand this and you know the basic changes of the hormones. We have a lot of slides, so this topic can come up with many slides. We have only from the uterus, we have 4 slides. Mammary gland is also responsive to hormonal changes. At the placenta, you will be asked about that too, and the ovary corpus luteum slide. So there are a lot of these slides where you will be asked about these hormonal changes. Part of it you already learned in the first semester, because you had to know the implantation was a topic, so you had to know that uterus is in the secretory phase during implantation, etc. So just repeating the main things, estrogen is produced mainly in the first half of the cycle. So this is after menstruation. We consider the first day of the cycle the menstruation first day. Although, if you understand the process, you understand that this is the end of the story, right? Menstruation is at the end when we build up the uterus endometrium and then it's shed off. So why do we consider it as day 1? Because this is what everybody knows. So this is from practical reasons that it's not the first day of the proliferation, which is logically the beginning of the cycle, but for practical reasons, because women know, okay, my menstruation began on this day. So this is very important for gynecologists to know when menstruation started. So for practical reasons, we consider day 1, the menstruation day 1, and then about 5 days later, when the estrogen levels start to increase, this is when the uterus endometrium will be built up. And this is the proliferation stage or phase of the uterus due to estrogen. Okay, I will show you this in detail, of course. Progesterone is mainly produced or almost entirely produced, almost exclusively produced during the second half of the menstrual cycle due to the LH, which induces corpus luteum building, and then corpus luteum will produce progesterone. And this induces the secretory phase of the uterus, the secretory phase of the uterus. If there is no fertilization, you can see the corpus luteum degenerates after this LH peak. It degenerates. Then there is not enough progesterone. Progesterone level decreases. So progesterone is, we need progesterone to keep the endometrium, the uterine endometrium, and so the endometrium will be shed off. If there is fertilization, then we have another hormone, the HCG, which is the pregnancy hormone. This is produced by the blastocyst, then embryo, the trophoblast cells. So it's produced by the baby, so to say, not by the mother. It's the baby telling the mother body, the mother's body, here I am, prepare yourself. So this is like this messenger hormone, HCG, and this replaces LH. It's very similar in structure to LH. So in this case, the corpus luteum survives, progesterone levels further increase, and the endometrium will also further increase, okay? And this is a very important difference. So we have a third slide from the uterus. We have proliferation stage, secretory stage, and then the pregnant endometrium, Decidua, which is actually the continuation of this. It doesn't stop here, but goes on. So this is very, very important to understand. So let's see the first phase, the proliferative phase. There is not much to show in these slides. It's mainly the theory that you have to know and you will be asked. It's the theory. So proliferative stage or phase, as the name tells you, everything proliferates. We talked about the glands, we talked about the stroma, and we talked about the vessels. the spiral arteries, everything grows. So the glands, the stroma, and the arteries from the remaining stratum basale, which does not go, which is not shed off during menstruation. The glands first elongate and then they become coily. It's another very important issue that you that you understand that it's a continuous growth. It's not something that looks the same on day 6 and day 14. Of course, it's a continuity. Every day it looks different. So that's why early proliferative stage looks different than late proliferative stage. Early secretory phase looks different from late secretory phase. So that's why I'm telling you this, because later, in the later phases, the glands become coiled, but they still do not secrete. So that's why I wrote it here with exclamation points. Coily does not mean secretion. Okay, only by itself does not mean secretion. It's not the same. So these glands here, what are coiled, if there are coiled glands and we make a section, then you see the glands like this in the section. But the lumen is small and regular. You can see that there is a regular lumen. And so the cells do not show any signs of secretion. And plus, the stratum basale here, stratum basale, looks the same as the stratum functionale. You will see in the next phase that it's not the case. All these slides that we have are cross sections. This would be a whole cross section from the uterus, right? And usually it's just a piece from this wall, like here, or just a part of the wall. So the stroma, here you can see the stroma, this very densely packed cellular connective tissue here. If we continue and go to the secretory phase, which is under the influence of progesterone, even the name tells you that it prepares gestation. It prepares it prepares the uterus for gestation, for pregnancy. Okay, so every cycle, every month, our uterus is prepared for pregnancy. In case fertilization happens, the uterus is ready for implantation. So that's the whole point. So these cells prepare the uterus for implantation. Here, if we go back to the cycle, ovulation is on day 14, and the egg lives about 24 hours. So if there is fertilization, it has to be around this time. And then the fertilized egg travels in the uterine tube, and when it reaches the uterus, it will be exactly the highest level of progesterone, and the uterus is prepared in the middle of the secretory phase for implantation. So this is how the timing is happening. So this is how it looks. Okay, here you can see the difference between the basal layer and the functional layer. They are completely different. The basal layer did not change. These glands are not secreting. Here you can see, or with higher magnification here, that these glands secrete because they have a very irregular shape. The glands, the lumen is very big lumen. The secretion is very rich in carbohydrates. It's a thick mucus secretion. It supplies the implanted blastocyst until the placenta circulation is established. So here could come, I just wrote here as a question that can come up in the exam, where else do we have glands with such big lumen? Later, we learn the prostate and the lactating mammary gland. So this is a usual question here. So very irregular and big lumen, okay? And the cells also show signs of secretion. They are swollen, pale cytoplasm, and the stroma cells are also like swollen and become epithelioid. This means that they become more and more densely packed. the stroma cells and tightly pegged, and they become bigger as well. They also store glycogen and lipids, and the spiral arteries form as well. I'll show you some more pictures. This is what it looks like. So it looks completely different. At the end, I will show you also a comparison between the different stages of the uterus. So here you can see this really big lumen, very irregular, as if it was torn, very irregular shaped glands. And again, don't forget that we can have early or late phase, late secretory phase, again looking different, completely different. At this stage, we can have a little difference already within the functional layer, the compact and the spongy layer, but really very, very marked change or limit or a border between the two. We will see in the pregnant uterus. I will show you another picture. If we enlarge the stroma cells here, you can see that if it was just shown to you without knowing where it was from and you didn't study the uterus yet, you would not guess that this is connective tissue because it looks so compact. This is what we call epithelioid, that it looks almost like epithelial cells, so compactly, so tightly packed. And at this stage in the secretory phase, we call them pseudo-decidua cells. Pseudo-decidua cells. Pseudo means fake, just like the pseudo-stratified epithelium, which is a fake stratified epithelium. So pseudo fake decidua cells. Decidua, you will soon hear, decidua is the pregnant endometrium. So pseudo decidua is the fake pregnant. This is not pregnancy yet. It's the secretory phase. So these are called pseudo decidua cells, which will be decidua cells when we have pregnancy. And in some places, you can see the spiral arteries very well. Again, imagine if we have a spiral artery, we make a section, then you see the cross sections like this. These are the spiral arteries. And the third phase is the menstruation phase. We don't have a slide from this phase, but you have to know the story, at least this much, or this much you have to know. So I already said that the spiral arteries are hormone sensitive. So what happens if there is no pregnancy? I just refer again to these graphs with the hormonal changes, that the levels drop, hormone levels drop, progesterone and estrogen too. So this leads to contraction, vasoconstriction in the spiral arteries. This leads to the ischemic phase. Sorry. This leads to ischemia if the vessels contract, and this causes cell damage, of course. No blood supply, so the cells start to disintegrate. And then even the wall of the blood vessels disintegrate, so the cells of the blood vessels themselves, so there will be bleeding. This is called the hyperemic phase. And if there is bleeding, you will learn this later in pathophysiology, pathology, that if an already dying cellular layer becomes suddenly blood supply, it does even more damage. So this hyperemic phase helps actually that the degenerated layer is entirely shed off, which is the functional layer. The basal layer has a different blood supply. There are no these things happening, so it remains, and then we start over again. Estrogen helps to build up during the proliferative phase, helps to build up the endometrium. So this is the menstruation phase. Here you can see the three phases next to each other. So proliferative phase, secretory phase, and menstruation phase. We don't have this slide. I'm just showing for completion this slide here. You can see all this blood between the stroma cells. And of course, here we need a factor that inhibits blood clotting, because otherwise there would be no bleeding. And with the bleeding is the uterus shed off, the uterine endometrium. Here you can see that there is a significant growth in thickness during the cycle, so 2-3 millimeters during the proliferative stage, and then further growth during the secretory phase. But this growth is mainly not due to proliferation, but mainly further growth due to further growth of the cells themselves. The cells secrete. Here, I'm sure you heard about this disease, which is unfortunately very common, endometriosis. It's when we have endometrium islands, little groups of cells like endometrium, just not in the uterus, but outside the uterus. Here you can see the common locations, but it can be basically anywhere in the body, but these are the common locations. And these are also undergoing cyclic changes. So you can imagine if you have cyclic changes of these endometrial cell islands, then you have cyclic pain, heavy bleedings, and even infertility. Unfortunately, it's a very common disease. Also, I'm sure you heard about uterine cancer, and this can grow from the body of the uterus, from the endometrium. Isthmus, just a few words about this transitional zone, so where the body and the cervix meet. This is similar to the corpus. The endometrium is thinner, and it is involved in the cyclic changes, but less, and it's quite passively dilating during birth. There is less vascular supply here, so this is where surgeons like to go in. And then comes the next part of the uterus, the cervix. But if we go back here, you can see that part of the cervix, the so-called vaginal portion of the cervix, is actually inside the vagina. So outside this part of the cervix is covered by the vaginal epithelium. So we can only discuss the structure of the cervix after we have done the vagina as well. So we will come back to this later. And now we continue with the pregnant endometrium. Pregnant endometrium is called Decidua. You already learned this in the first semester when we did embryology, and you have seen these pictures as well, where the implantation can happen, which parts of the uterus the egg can, or blastocyst at this stage, can implant. And the black line shows the endometrium, and this has different parts. We have the Decidua basalis, which is where the placenta is formed. Then the capsularis, which surrounds the rest of the embryo. This is the Decidua capsularis. And then all the rest, where we have no embryo parts, no fetal parts. This is called the parietal Decidua or Decidua parietalis. Okay, this is the pregnant endometrium structure. It looks the same and everywhere here. And this is where our slide is from the Decidua parietalis. Okay, but it's actually the pregnant endometrium. And just to repeat, so what happens now that you understood this picture, the secretory phase, this does not end. If there is fertilization, HCG produced by the trophoblast cells keep the corpus luteum progesterone, and progesterone level further increases, so the endometrium will further increase. It doesn't end. The secretory phase doesn't end. And that's what we see here. So this is the secretory phase that I've already shown you, and this is the Decidua parietalis. I told you that in the secretory phase, you can kind of distinguish the compact layer from the spongy layer. compact layer, the name tells you that it's where the cells are more compact. Spongy is like a sponge. So these are the really enlarged glands. But really distinguish it, you can these two layers in the Decidua parietalis. You can see here the difference. This is the spongy layer with the enlarged glands, sponge-like appearance, and this is the compact layer. Here you can see if we enlarge this layer, that cells are really compact, they are enlarged and really tightly sitting next to each other. This is what we call epithelioid change. They almost look like epithelial cells with storing glycogen and lipid, and this is what is accumulated, and it provides nutrition for the blastocyst till the placenta circulation is done. This is really characteristic, these Decidua cells. If you go to high magnification, this is what they look like, very characteristic, these cells. Really enlarged, you can see the huge cytoplasm, and the cells are really big and very pale. Cells are very pale. This slide is many times mixed up or not recognized at all. Here, of course, in a digital form, it's easier because we know students just memorize the pictures. But the theory, you do have to know, you have to be able to tell why you think this is the Decidua. How do you recognize the Decidua cells? So please remember this picture. And now, before we do the cervix, we have to do the vagina. This is an easy slide. It's easy. Most of the things you've already learned, for example, the epithelium and layers of the epithelium. The three layers of the vagina as an organ are the usual layers: the mucous layer, the muscular layer, and the adventitia. It has adventitia, loose connective tissue. The muscular layer, although it has an inner circular outer longitudinal layer like most organs, it's not easily separable, and it's really intermingled with connective tissue fibers, collagen and elastic fibers. So it's not like in the esophagus or in other parts of the intestinal system, where you can really see the inner circular and outer longitudinal layer separated from each other. This is not the case here. It's an intermingling, so-called fibromuscular layer. And then, of course, we have to talk more about the mucous membrane, the mucous layer, which has the epithelium and the underlying lamina propria. The epithelium, you can easily recognize, and you know it from first semester already. It's a stratified squamous non-keratinizing epithelium. Vagina was another example when we asked where else do we have stratified squamous non-keratinizing epithelium, like in every body opening. Vagina is another typical example where we have a very thick stratified squamous non-keratinizing epithelium. Don't forget that we can ask first semester things like what are the layers of this epithelium. And so here it's really thick and very pale because of the lot of glycogen that is stored here. This is a pus stain slide. You remember pus staining is for carbohydrates, so glycogen stains very well with pus. And here you can see how purple the top is, the top layers. Actually, the esophagus would be the same. So actually, it is typical for stratified squamous non-keratinizing epithelium, especially if it's thick, that the upper layers do not get enough nutrients, so they store energy in form of glycogen. So this is typical. Maybe the vagina has a little bit more glycogen, but just the epithelium looks the same as in the esophagus. So how do you distinguish the two? I will tell you soon. So this is the top, and you could ask, why does it have so much glycogen? One, for nutrition of the cells, and second, it's actually very good that we have all this glycogen. Of course, the top layers are continuously shed off, as in every stratified epithelium. And we have our bacterial flora, bacterial environment, these are the so-called lactobacteria, look like this. These belong to the normal flora. Normal flora means that we live together with billions of bacteria, and under normal circumstances, they are our friends. They belong to the normal flora, and they protect us from the enemies, from the bad bacteria, and they produce from the digested glycogen from the cells that are shed off, they produce lactic acid by fermentation. So this lactic acid, which is a weak acid, renders the vagina this acidic pH, and we always ask how acidic it is. Of course, please don't say 1 or 2. It's not that acidic as the stomach. So it's a mild acidic environment, 4, 5. Okay, and it's very important because if this bacteria balance is disturbed, for example, by taking too much unnecessary antibiotics, then these bacteria are also killed, and then come the ugly ones, which cause all kinds of infections. So fungi and other bacteria can settle, can colonize if this pH is disturbed. So under the epithelium, of course, we have the lamina propria. What you can immediately notice is that there are no glands. This could be a difference already between vagina and esophagus. This is intertwined elastic fibers and with the muscle layer, so it's really not easy to see the next layer begins. And if we have no glands, you could ask, how is the vagina kept wet? Because every mucous membrane has to be moisturized. And this is the mechanism. The most important one is the cervical glands. Cervical glands produce mucus, and this goes kind of flows down to the vagina. We have other things too, for example, the Bartholin glands, lactic acid from the glycogen that I already mentioned, and transudation. But the main thing is the cervical glands, which ceases to produce after menopause. So after menopause, dryness, vaginal dryness is a true clinical problem, because if the epithelium gets dry, then infections can happen, inflammation, infection, and it's itchy. So this is actually a problem of many women after menopause. In our slide, we can see many other things. Of course, the connective tissue papillae, cross-section, longitudinal section. We can see lymphocytes just scattered or in form of follicles. And you can see here this fibromuscular tissue where the muscle cells are intertwined with the fibers. So it's not so clear muscle layer, not so clear muscle layer as in the esophagus or intestine slides. And of course, nerves and blood vessels are found as well. This PUP test is a very important test clinically, when the gynecologists take sample, and then we can see the shed off cells. And these cells, these are the nice looking squamous epithelial cells. These are the normal looking cells. And for example, this case looks shows an infected case, infection, and these are the fungi. So this is an important examination. In other slides, I wanted to show you the rectum slide, because in most of our slides, we can see a little piece of the vagina here, little piece of the vagina next to the rectum. And please don't mix it with the esophagus. As I already said, apart from the epithelium, nothing is similar. So it's really not nice to mix them up, because the epithelium looks the same, but the layers are completely different. Okay, esophagus has the 4 layers typical for the GI tract, has really clear lamina muscularis mucosae and very thick inner circular outer longitudinal muscle layer, so looks completely different. Okay, and now we can go back to the cervix as the last part of my lecture today. So cervix here, That's a very important part of the uterus because this is what closes the uterus and stays closed until birth. And it's very important for preventing premature birth and also for preventing ascending infections. As already mentioned many times, the female genital system is open to the outside world, so easily ascending infections can happen. It has a thinner, less muscular wall, but more connective tissue, and even macroscopically visible folds, which are called the plicae palmatae. And between the folds, we have the crypts. So in every drawing, you can, even in a very basic drawing, you can see these folds and crypts between them. And of course, during birth, it has to enlarge from being closed to being able for the baby's head to go through. And the mucous membrane has less changes. It does change, but has less pronounced changes during the cycle than the less than the corpus. The epithelium is higher, less cilia. We have mucus secretion, as I already said. Very important, this mucus for moisturizing the vagina wall as well. And the glands here are much more branched than the corpus glands, where we only saw at the very basal part some branches. So here you can see also these big, in our slide, these big branched glands. Some of them can be so big that even cysts are formed. And this mucus is different in composition during pregnancy because it builds a plug. It's called cervical plug. It's a very thick mucus, which is very important, of course, for preventing infections and keeping it closed as well. And before or when birth begins, then this plug also leaves. What is important histologically is that we have the inner and the outer surface different. This is called endocervix and ectocervix. Endo, ecto, or exo, both names are good. So in the canal, we have the uterine epithelium, the simple columnar epithelium, and then it changes here outside. You see, the cervix is kind of embedded in the upper part of the vagina. So in this outer part of the cervix, we find the same epithelium as in the vagina. So from simple columnar, we change to stratified squamous non-keratinizing epithelium. Endocervix, ectocervix. Very important, this junction is very, very important. It is called squamocolumnar junction because it's a transition between columnar and squamous epithelium. It's also called transformation zone. And you can already guess that where we have such an always changing, a cyclically changing epithelial switch or transformation, transition, this will be a very active zone. This is exactly where malignant transformation can happen. So it's very important. The position changes. You can see here, this is before puberty. The junction is where you would logically put it at the os, at the external orifice. The red part shows the squamous, and the blue is the columnar. So it's at the external orifice. But at puberty, after puberty, so during the cyclic changes, actually this exact line is changing. It goes more outside the columnar zone. This transition is located more outside, becomes visible macroscopically, and this junctional zone which is really sensitive to virus infection, and this virus is the one responsible for the malignant transformation as well that we see in cervical cancer. Our slide is the longitudinal section. Here you can see the cervical canal very well, and actually there is not much to show. You can see the stratified squamous epithelium, and you can see the columnar epithelium. Sometimes you can see very enlarged spaces. These are the cysts. These are grown from the enlarged glands. And just a few words about the cervical cancer. You have to mention this here, that it grows from this transformation zone where it's always changing. So you can imagine this is always changing epithelium is prone to malignant transformation. And this is what the different stages look like. It's a common type of cancer in women. Here you can see, of course, you don't have to know details from this slide. You will learn this later in pathology very much in detail, but you have to know that the transformation zone is where this very active epithelial change happens, and this is what is vulnerable to a malignant transformation as well. And that's why screening and checkup is very important, because unfortunately, it's a common type of cancer. Fortunately, it grows very slowly. So in most cases, if somebody goes to a checkup every year, which is how it's supposed to be, then you can catch it in time when it still remains inside the epithelium, so it can be removed. Just that part can be removed, and it can be 100% cured if somebody goes to checkup. And unfortunately, it's not a cancer of only old people. Young women can have it too. So this checkup with the smear, you see the nice normal looking cells, and this is a malignant transformation. It's a very easy exam and very important. So finally, I just show you the 4 slides as a summary, the 4 uterus slides. We don't only have proliferative and secretory phase from the uterus, but the decidua is from the uterine wall, and the cervix too. Cervix looks completely different. This is never mixed with these other 3 slides, but unfortunately, these 3 slides, even online, can be mixed up with each other. If you learn the basics, what I told you today, with the morphology of the glands, with the morphology of the stroma cells, you cannot mix them up, because here there is no sign of secretion in this. Lumen is small, the gland lumen is regular, and the cells are regular too, not pale. Here you can see the difference between stratum basale and functionale. You can see the enlarged, really irregular looking glands, and the lumen is big. If you go to the stroma cells, you can see that they look different, more compact, and start to become more rounded cells. And then the pregnant uterus, you can see the huge decidua cells. You can see the difference between the spongy and the compact layer very well. Here you can only kind of see it. Here you can really clearly see the spongy and the compact layer, and if you enlarge in the compact layer, you can see the huge decidua cells. So if you remember these things, and then you won't have problem recognizing the slide. So this is how much I wanted to say today, and see you next week. We go on with the placenta.